Well, good morning, everybody. I am Dr. Laura Lacher, and welcome to today's Medical Grand Rounds. As usual, we'll get started with some reminders, some logistics, and then introductions for today. Please be sure to come join us in person here in Souther Auditorium. Next week, we will be hosting one of my favorite Grand Rounds. Our internal medicine residents will be presenting posters that they will be sharing at this year's Oregon ACP, American College of Physicians chapter meeting, which is occurring next week in Portland. So please be sure to join us for their great work next week. Grand Rounds is now a joint effort between Providence St. Vincent and Providence Portland Medical Center. We are often here live in person at St. Vincent Tuesday mornings at 8 a.m. and sometimes live in person at Providence Portland on Tuesdays at noon. You can always join us on Teams Live at the virtual platform, and welcome to those of you who are out there on Teams Live today. You can earn CME credit by being here in the room, by watching live virtual, or by watching a recording of the event. That recording is available at the same link as the Grand Rounds invite. And the Grand Rounds invite will also always let you know whether or not we are live in person. I'll be keeping an eye on the Q&A on the Teams Live throughout today's session. So please go ahead and post any comments or questions that you have. And I'll mostly hold those until the end as time permits. We are very fortunate to be joined today by Dr. Andy Seaman. He's Associate Professor of Medicine at Oregon Health and Science University, as well as Medical Director of the Hepatitis and HIV Services at Portland's Central City Concern, and Head of Substance Use Disorders at Better Life Partners, a harm reduction framework substance use disorder treatment program providing services across New England. Dr. Seaman is board certified in both internal medicine and addiction medicine. He is a harm reductionist, an educator, researcher, and activist for the rights of people who use drugs. His research centers on the intersection of hepatitis C and injection drug use and the implementation of harm reduction in healthcare systems. Thank you so much for joining us today, Dr. Seaman.
Thank you. So I also went to residency at Providence Portland and finished 12 years ago, I guess. It's been a journey since then. My first Grand Rounds was at Providence Portland my senior year, where I changed some laws around HIV screening, and it's an interesting experience to be back here now. So I live in Vermont currently, and I do some virtual work around here, but it's really great to be here. So this talk is really centered on my work around hepatitis C elimination, which I still do some of that here in Portland, Oregon. I run the Hep C elimination program at Central City and do some research still around this at OHSU. These are my disclosures. We're going to talk a little bit about the elements necessary to achieve Hep C elimination through the lens of the Oregon experience, and kind of starting at, where do you start, which is really just with one person, one clinic, one patient, and then how do you build from there? And then a lot of the talk, and it's a little data heavy, but it is designed to think about how do we use the concept of care cascades to design programs, iterate upon programs, and make care better. And then specifically with hepatitis C, I'd love for anyone watching here or online to just be thinking about, what's my role in Hep C elimination? Here's some terms that I'll be throwing out through the talk. The concept of microelimination is that we choose a system, whether that be your clinic, your patient population, your health system, your city, your town, your state, and so on, and focus on systems to eliminate an infectious disease from that health system. Macroelimination is more of the broader picture from a public health perspective. And DBS is a term used some, it's dried blood spot. It's a kind of testing mechanism I'll talk to you about. OTPs are opiate treatment programs. People who use drugs are people who inject drugs. Peers are people with lived experience, in this case of substance use and involvement, and their involvement in improving health outcomes for people who use drugs. MOUD is what we now call medications for opioid use disorder. SSPs are certain service programs. So today is a really interesting day to give this talk in that we have an election, if anyone's aware of that right now. And excuse me, this is something that did not get as much press as it should have. But in 2013, the Biden administration proposed a truly historic piece of legislation aimed at eliminating hepatitis C. It's the Ryan White Act of Hepatitis C. And the difference between Ryan White and the Hep C elimination program that the Biden administration has put out there is that this is something we can cure. It is very rare that we have a disease that is as morbid as hepatitis C. It kills more people than just about any other virus that we can cure, we can eliminate, we can remove it from the human pool. And it relies on increasing funding for screening, linkage to care for the 2.4 million, probably more, expected to be living with hepatitis C, and they decrease some medication costs. And another very rare thing about this disease and this movement is that treating hepatitis C and curing Hep C, despite what we have all heard about the drug cost, is cost savings, likely cost savings. So there's no reason we shouldn't do this. And yeah, it's rare to have this opportunity to use simple and safe oral medications to eliminate a lethal disease. And that's where we are right now. So what happens today will really impact what we can do in the next 5 to 10 years. And I'm really hopeful that we can do this work. All right, so some background. So besides treating hepatitis C, getting people with opioid use disorder on medications to treat opioid use disorder is one of the biggest things we can do to address the hepatitis C epidemic. There's approximately a 50% reduction in Hep C transmission for people on medications for opioid use disorder. The reason for this is partly because people are less likely to use, maybe they're more likely to be in remission or recovery, whatever word you want to use. But so much of it is because people do not get Hep C because they inject drugs. They get Hep C because they're desperate, because they are without choice about when and how they inject drugs, because they're often injecting in compulsive situations where they're sick or they maybe don't have any ability to make choices, like they're in an intimate partner violence situation or something like that. And so we are trying to allow people to have the choice of when and how they use if they do use, and recognizing that Hep C is so much more than just a virus. And then obviously harm reduction, access to syringe service programs, safe injection equipment has a strong protective factor against Hep C transmission. You see this really big range here. This is another meta-analysis from University of Bristol. The range has to do with you really need to have adequate supply, adequate access, not just access to syringe service programs. And the larger percentage reductions in transmission are in places like in Europe, where the penetration is really good, whereas the lower impact on Hep C transmission comes largely from the States, where it's really haphazard, and also where maybe people, there are laws and other stigmatization around engaging in syringe service programs. And then this is a picture on the right here of a safe injection facility in Australia. And this is a picture on the left here of a place someone might be injecting in the UK, where this picture was taken. So you can kind of see why possibly it might be a safer thing for people to have access to a safe injection facility as opposed to in a dark alley or corner somewhere. People share injection equipment when they're desperate. MOED, like I said, gives people time, and peers, harm reductionists, save more lives from naloxone reversals than anyone else, than providers and doctors, and they're really heroes. This is a slide that came from a meta-analysis looking at people, this is now old, 6 years old, people who were actively using drugs or recently using drugs and treatment of hepatitis C. When I first started doing this work, which I'll talk to you about, in Oregon, we couldn't treat people with any access or any involvement with addiction, whether they were actively using or not. They had to be engaged with a substance use treatment provider. And we started our treatment with a drug company grant because we could not get people treatment otherwise. And there were no data at that time when we first had our first study through Merck. And now we have, this is old, there's many, many, many thousands of people who've been treated. And you can see that the treatment completion rate at that time was very, very high, despite what people would say is that people who use drugs aren't going to take their medications, they're just going to get reinfected again. I don't think I have a reinfection slide in here, I might, but the reinfection rates are real, but they're low. And if someone is reinfecting, that means they're also infecting other people. And so if we need to be treating people regardless of reinfection risk. The SVR12 here is, SVR12 is cure. I didn't have that as a definition of terms, but SVR12 refers to someone who had hepatitis C, was treated, and then 12 weeks after their last dose was negative for hepatitis C. And the rates are lower than you'd see in a drug company trial, which is like 98%, 95%. But a lot of this has to do with the fact that these are hard, it's hard to get people in to complete their labs. So most of these people would also have been cured. We just don't have data on them. The numbers are lower now, and I'll show you more about that and why. All right, so zooming into Oregon, this is a map of Oregon, also quite old data at this point. I think most of these data are from the early teens, around the time when the DAAs came out. Darker is higher prevalence, and you can see that Hep C is not an urban problem, which is very different from HIV. In fact, the highest rates tend to be in rural America. And here we are in Portland. We don't have new data on this either, but we still likely have one of the highest mortality, morbidity, and prevalence of Hep C in the country. And then a lot of my work started at Central City Concern at Old Town Clinic, and then expanding outward from there. And most of you may be aware of this, but it's a supportive housing organization, as well as residential care and integrated healthcare for the homeless organization, with their tendrils all over, especially downtown Portland. So we started with just myself and one other doctor and a pharmacist, and we started, we saw all of these people coming through who had Hep C. No one was treating them, despite the fact that we had these really, really effective medications. And at that time in Oregon, we had some of the worst restrictions on treatment and Medicaid in the country. You had to have cirrhosis and some MELD score criteria, no substance use, and only specialists could treat. And it was maddening. It was one of those things where you're like, this cannot be. And so that's when we started looking for some other ways to treat people, including starting with a pharmaceutical company investigator-initiated grant. As part of that grant, we did a qualitative analysis where we talked to people after they'd been cured. These are people who are actively injecting. That was one of our criteria. And it was a semi-structured qualitative study, and people reported more self-efficacy after the cure, less chaotic substance use, more harm reduction, engagement, and better relationships. And so one of the things that, again, Hep C is not about the virus. It's not a liver disease. It's a systemic inflammatory disease. But the reason I do this work is because people, like I said, they get Hep C when they are in these moments of extremis, in these highly stigmatized moments, and they're carrying that around in their body until it's gone. And so when you cure Hep C from someone who uses drugs or used to use drugs, you're removing this internal reminder of all of those moments and of all this in kind of imbibed stigma. And it really can be transformational for people, and they feel better too. And you can imagine, say, like a woman who is, in the hospital, has just given birth, all of the fears they have around giving the virus to their child and so on. And we're removing that. So this is social justice work, and I really encourage you all to get involved with it. So we started at Old Town Clinic with what we had. We had a very high prevalence of hepatitis C at that time. Most people just said, oh yeah, I just have Hep C, and people would just sort of look away and not do anything about it. And we had a lot of heart and very few systems in place. We were doing only risk-based screening at that time. If people told us that they maybe had used drugs, that maybe we would screen them. And this is their kind of intro to the care cascade here. So we start out in almost all of these care cascades that you'll see with just the number of people who we could be screening. And then in this case, we were doing at-risk-based screening. We didn't have any systems in place. We had about 2,300 people who were deemed to be at risk. And of those, about half had completed a Hep C antibody, and 456 at that time had a positive PCR. And over the course of about the first year, we initiated 188 people on treatment. About 50 of those came from the study. So these are people who had study drug and they were actively using drugs and couldn't get treatment elsewhere, or maybe they had a high fibrosis score. And of those, 160 completed SVR12, and we had one treatment failure. So this is before we had data on people who use drugs, and clearly in our study, our setting at least, we were able to get these people through treatment. So very high cure rates, but relatively low rate of people initiating treatment. So the reason why I love care cascades, and I use this in my other SUD work and all across my work, is because it's just a great, very simple visual to look at where your gaps are. So right now we have this big population of people who are in the primary care clinic. We think that only this percentage of people have risks, but many more of them may. And we had a big gap in the number of people who were screened. And so you look at this and we look at this gap and you say, so how do we address this part of the care cascade? And so we knew that the evidence suggested that universal opt-out screening was the gold standard. And so we wanted to move to that. And one of the things that I've taken from this work is that identifying bottlenecks is the way to go. What does everyone have to do in your setting? Put your intervention there. And so for us, that was, at least for the new folks coming in, that was intake. And so we took the screening out of the hands of providers and nurses and MAs and put it into the hands of the front desk people. We gave them a simple questionnaire that they did. They clicked a button and then they would order labs and they would get people in. And then we also had to address this part of the care cascade, which was just the once we had folks who, and we knew they were HCV positive. And so I'm going to focus just on this part of the care cascade, same data. So at that time, the first year, the 456 people who had a positive PCR, again, we're just kind of ad hoc treatment. We were doing our best to get people in, and 188 of those people had gotten treated. And so we knew we needed to streamline our referral processes. And then one of the big barriers at that time, as I mentioned, was the prior auth. There were so many limiting factors on who we could treat, who could treat them, and so on. And so we started to organize against the prior authorization restrictions and took it to the state. And over the course of 4 years or so of consistent presence at the P&T committee, we're able to chip away at the substance use disorder requirements, the provider restrictions, the fibrosis scores, and by 2019 we were down, I think, to F1, maybe something like F2, and then somewhere in that next year got rid of fibrosis restrictions altogether, and then ultimately in 2023 got rid of the prior auth, which is truly the biggest barrier. It's just the presence of a prior authorization and having to ask people, when you have people who are houseless, actively using drugs, and they're coming in, we're like, we'll submit a PA. It doesn't work. Just have to get rid of it. This is a curative treatment. So 1 year later, we really started ramping up these systemic issues. We'd had implemented universal opt-out screening at intake, but we needed to expand our pool. So we added an additional clinic. The Blackburn Clinic started up around that time. And so our screening pool went up to about 6,300 people. And we implemented this universal screening. The percentage of people who were screened overall in the clinic it went from 31% to 46%, which isn't a huge leap, but that was partly because we were really only at that point addressing new clinic patients and hadn't yet figured out how to screen the individuals who were already in our system, which is sometimes a harder thing to do because, again, find your bottlenecks, and we had a harder time doing that at that point. We're going to go again just to the treatment cascade. So Of those, at that time, the 834 people now that we've diagnosed, about twice, 2.5 times what we've diagnosed before, we had increased our percentage initiating treatment from 41% to 68%. Some of that was the prior authorization barriers being reduced, but a lot of it was how we tried to address the prior authorization. So we set up a system where anyone who had a positive RNA would have these standardized follow-up lab work done. But still took a lot of like outreach and reminding people to get labs done, and maybe you'd get most of the labs done and not one of the labs, and so the prior auth would be denied and you have to have them come back again. So we started to work on those systems, but then part of the reason we had this kind of pre-review process where a provider, without having seen the patient, would write the prescription is because now when the patient came in, their medication was already approved and there wasn't a delay. If you're doing that at the time of the first visit, you're going to lose them. Bottom line with the care cascade science is if you cut out steps in the care cascade, you'd get more people through the care cascade. So that was really all the work we were focusing on at that point, was cutting out different individual steps in the care cascade. We had some enhanced care coordination, so now we were able to, we use 340B fundings, which is the funding mechanism for FQHCs and other nonprofits, where you get to buy drugs at a lower cost and then can sell them at the normal cost. And so you make a lot of money off of these medications when they are very expensive. And we put all of that money back into systems to hire outreach workers and coordinators and other things that we needed to get this work done. And one of the things that we were trying to address was making sure that every single time someone got lab work done, that they got all of the labs that we needed for the prior auth. So I went to LabCorp and developed this one-click screening to treatment lab algorithm, and it took a couple of years, but it's something that now anyone can use at LabCorp. And it looks like this. Basically, we would have this is for our front desk staff. They would click the order button. They would get a Hep C antibody reflex to RNA, Hep B surface antigen, and HIV antigen antibody. If the Hep C antibody was positive, they would get a reflex to all the other labs that we needed to treat people: CMP, CBC, surface antibodies, HIV antibody, and then if they were someone with a uterus, then they would get a beta HCG as well. And we published on this in the International Journal of Drug Policy. And if you look on the right, the Kaplan-Meier curve, you see that the people who, these top two lines are, this is pre-bundle implementation. This is the top two lines are post-bundle implementation. What we found was only that it decreased time to treatment initiation. It didn't decrease overall or increase overall treatment. Part of that was at this point, we had this team of harm reduction focused, really skilled outreach workers and coordinators who were able to continue to track them and build relationships and get people in. If we did not have this, I'm really convinced that this would have actually increased treatment initiation as well. Also, because of our prior auth kind of mitigation processes, like we were able to sort of move things through that might not have already moved through. And that's really where the enhanced care coordination comes in. What we saw, though, and this is another thing you see with care cascade science, is that if you decrease the barriers at the earlier parts of the care cascade, you make it more challenging to retain people later in the care cascade. So we started to see that the percentage of people who were completing those SVR12 labs fell from 85% to 68%. These are people who we decreased the barriers to get in, and so we were able to treat a more complex population, a more disengaged population. And yet we still only had 2 treatment failures at this time. So while our cure rates, our confirmed cure rates were only 68%, we only had 2 treatment failures. And at the time, the data suggested in the UK and elsewhere that the people who did and did not complete their SVR12 labs probably had about a similar cure rate. So whenever we see these numbers fall, it makes us feel bad, but probably this means we're doing the right thing. All right, so now, and I hoped to update our data. These data are now a year and a half old. Unfortunately, the internet on the plane last night was not working, and so I couldn't access our data. I was waiting to the last minute as usual. But so there are you can add a few thousand people screened and 500, 600 people treated at this point, but we're looking at the first part of the care cascade from the entirety of our program from early 2017 through March of last year. And now you see that of all the unique individuals that have ever are engaging in any way with Central City Concerned Health Services, almost all of them have been approached for screening. And this was achieved in a lot of different ways. At this point, we had 11 different supportive housing centers that were being screened at. People who were doing this new test called DBS, which I'll talk to you about, that we brought in, self-screening and also some outreach worker assisted screening. We had integrated screening into Hooper Detox, or medically supported withdrawal center, 6 opioid treatment programs, so those are methadone clinics, which we used dried blood spot at, and I'll talk to you about that briefly. We had dozens of street outreach sites where people could come on a regular basis. We were paying people financial incentives to be screened and also to refer others in to be screened, and a lot of other community partner sites, including some hospital referrals. So a lot of this is about increasing your web, increasing interconnectedness, and at some point, if you have presence all over the place, you will find people and you'll at least ask them if they want to be screened. And then still though, a pretty big gap here, a lot smaller, as you can see at 40, excuse me, the percentage of our overall engaged population screened went from 46% to 62%. We still have this gap here, although again, most of these people have been approached for screening. So some people have been declining screening appropriately, like they just were screened. Other people just didn't want to be, but it's a relatively small percentage of those who now really should be screened or rescreened who were did not yet know their status. And a lot of this again is incentives. So we paid people $10 for a rapid point of care test, $15 for completion of an RNA confirmation. At the time of results, we would pay those incentives. And really, incentives are about a sign of respect. If you're houseless and you need a can so that you can stay well or so you can have food or whatever, you have trade-offs. And so if you're saying, hey, come in and do this thing, you're like, yeah, but I gotta take care of myself. And so it's about compensating people for their time. This is a public health problem. Another issue is that getting blood via phlebotomy is very challenging for people who inject drugs and also just for people who don't want to come into health settings, people who find them very stigmatizing. Many people need ultrasound guided blood draws in order to get blood out. And dried blood spot is something they at that point had been using in Europe and Australia and other places for a long time. We used it here for neonatal screenings. It's just like a fancy piece of paper called Watson paper. You poke someone's finger, you can do it anywhere in the field, and you just drop a couple drops of blood in each little spot and let it dry, and it's very stable for a month or more, and send it into the lab. So I, along with a couple of other people, developed this, what I call the treatment ready card, which is trying to get to the point of how do we make it so people don't ever have to go into the lab. You know, the dream was we screen people in the community, we deliver them their meds, they never have to step foot inside a health system that has been stigmatizing them for a long time. And so this was HCV antibody reflex to RNA, HIV antigen antibody, and Hep B surface antigen. You need the surface antigen because people who have comorbid hepatitis B, when you treat their hepatitis C, you can have a reactivation of hepatitis B, and it can cause, in very rare cases, severe hepatitis or sometimes even fulminant hepatitis and hepatic failure. And then we also wanted to do this hepatitis B core antibody, which honestly is probably not that important. If you have a positive core antibody, it means you've been exposed to hepatitis B. And again, in these very, very rare cases, you can get a reactivation of Hep B in that case, even when their antigen is negative. And so, you know, in the guidelines, you do hepatitis B core antibody. If it's positive, you do some repeat liver transaminases to see if they've had a reactivation. In practice, it's probably not necessary, but I wanted to develop, when we approached a lab called MTL based out of Vancouver to validate dried blood spot for the first time in the States, for HCV RNA. We also asked them to do this core antibody, mostly just knowing that many providers are conservative and they might want this. And so if we're going to do this without phlebotomy, we need to be able to provide all of the labs that some providers are going to want to see. And so we did a validation at Central City, did phlebotomy labs and dried blood spot, and we're able to do a lab-based validation and show 100% sensitivity and specificity for HCV RNA down to 600 international units. And so that's not perfect, right? You can get, you can have lower viral loads than that, but the question is really how many of these people who have really, really low viral loads actually will have a meaningful, when you're screening someone in a general population, will go on to have chronic hepatitis C, how many of them are clearing, and so on. So it's not perfect, it's not perfectly sensitive in life, but in the lab, it was quite sensitive down to low viral loads. All right, so looking again just at our treatment cascade at this point, after 5-ish years in the program, we had our close to 6 years. We had been, we now had initiated treatment on the vast majority of people who we had diagnosed with hepatitis C. And a lot of this again comes down to the web. So we were not getting all of these people in right away. The average time to treatment initiation was like 60 days, but the range was really huge. You would diagnose someone and then you'd lose them again, but then they'd show up at Hooper, or maybe they'd show up in housing, or we'd see them on the street, and our team had relationships and we knew them. And we didn't pressure them, but we just tried to help move them along. And so eventually we'd get people in. That's really where a lot of this change in our percentage of initiation came in. And at the time, this was some of the best numbers in the country for this population. And a lot of it is, again, it's creating that web, being visible, being kind, being slow. And then we removed the prior auth for DAAs in beginning of 2023. And that allowed the whole dried blood spot thing, all of that was all about getting to this moment where we could say, okay, now we no longer need to send all these other labs. It really rarely change treatment. At this point, we have now 2 pan-genotypic agents. There's another one in the pipeline, but that is Sofvel and Glipib. Both of them are pan-genotypic. You can treat any genotype. Realistically, there's no meaningful difference. One of them, the Glipib, is a protease inhibitor, which means that if you have really high liver transaminases or you have decompensated cirrhosis, maybe you're at increased risk of hepatic complications with those medicines, but it's really rare. So we went from before, where we had to get their fibrosis status to know what medication they needed and for how long, to really you could just like lick your finger and stick it up in the air and throw medicine at someone and you're going to cure them 99% of the time if they take their meds. And so we refocused on figuring out how are we going to figure out if someone does have decompensated cirrhosis or not if we can't get them into the lab. So I developed a questionnaire called, we call the Decompensated Cirrhosis and Hepatitis C Screening Questionnaire, or the DCHEC. This is currently under review at the Journal of Viral Hepatitis. We looked at 1,746 people consecutively. One of the things we did really, really early on is we developed systems to collect these data in a really high fidelity way. So we have really a prospective cohort from the beginning of their full care cascade and a lot of other risk factors and so on. And we identified all of the people who were diagnosed with decompensated cirrhosis at some point in their care. And at that point, again, most of these people are getting, extensive laboratory work and sometimes elastography, other imaging. So we felt pretty confident that we had diagnosed the vast majority, all of the people who had been exposed to our treatment team and had a positive RNA. We're getting this work up, and so we felt confident that we had diagnosed all of the people who had most of the people who had decompensated cirrhosis. And then out of the non-decomp population, we randomized 130 people, controls, and then we did a really thorough chart review based on what are some of the known primary risk factors for decompensated cirrhosis, which were, age. So there are some other previous studies that showed that if you're less than 40, you have a very, very low risk of having decompensated cirrhosis. Alcohol use, obviously, and we wanted to look at both heavy alcohol use, we extrapolated these data from some other risk tools, and then more recent alcohol use. And then just, have you been told you have extensive liver disease, and have you been told that you ever had liver failure? And there's a kind of a composite question that we asked. And then we scored their charts. So this is retrospective chart-based review in a single system in Healthcare for the Homeless organization. And with a score of cutoff of a score of greater than 8, we had 100% sensitivity in our population retrospectively for decompensated cirrhosis. Clearly, that's different than a prospective survey. So this is something that needs to be validated prospectively. We're currently doing that, at least in a smaller way, and looking for partner sites with higher decompensated cirrhosis populations to validate it prospectively. But in our population, we felt good enough about this. I felt good about this to move forward and starting to use this, especially because even if we miss a case, the risks to the patient is very low of treating someone. The biggest risk is that you have about a 10% decreased chance of curing them, which you have a much, much lower risk of curing them if you don't start them on treatment. So, and I'm not going to go into the details of this, but even though, the biggest differentiator in this was the question around, do you have a known liver disease history? And so at first we're like, wow, is this even really going to work? The D-check still outperformed. This is a receiver operating curve, looking at operating characteristics for individual components of the screening question. We also looked at FIB4 and some of the other fibrosis, lab-based fibrosis assessment tools, and the D-check outperformed them. So this is something that doesn't exist anywhere else that we're aware of, just screening tool, a question-based screening tool for decompensated cirrhosis. And we started implementing it essentially as soon as the PA went away, as soon as we no longer needed those labs to get to be able to use these DAAs. And we've been doing that ever since. And the vast majority, 80+% of people who we screen with a dried blood spot or any other lab-based test, we can initiate treatment now without sending them to the lab. I'm not getting into this in this talk, but I'll say that there's a whole other side of Hep C, which is liver care. So one of the things I've been trying to push the guidelines committees on is to really separate Hep C and liver care. There's Hep C, which is a virus. Let's cure it. We have medicines to do that. And then there's liver disease, advanced fibrosis, cirrhosis. We need to get ultrasounds every 6 months for people with F3 or greater fibrosis to look for hepatocellular carcinoma. But we need to keep them separate. And so you still need to take care of those things. It doesn't mean some of these people don't need those labs or elastography, but let's cure the virus first. So this is what this looks like now. We do a dried blood spot test and a core antibody, and we do the D-check questionnaire. If their score is less than or equal to 8, we will treat them with DAAs, and if their Hep B surface antigen is positive, we'll start them on hepatitis B treatment as well during treatment. And so it's really, this is, coming back to the steps of the care cascade earlier, where we had probably 10 different steps if you actually get to all the different, like coming back to the lab again and again, we poke someone's finger in the field, we get them their medications. We were also trying to figure out how do we, as you get further into elimination, you're going to have people who fail treatment, you're going to have people who, stop taking their medications, which is more common about halfway through. And so we really needed to increase the percentage of people completing those labs. But again, it's a trade-off. At this point, we've told people, if you take your meds, you're going to get cured. And so why would you come back and get your lab test done? Or maybe we just lose you, because that's three months is a long time to wait. And so we started to use DBS for SVR12, which has not been done elsewhere either. And we had to extrapolate some data, which is that if you have a true treatment failure, you usually have about 5-6 logs, like you have about 100,000 viral copies or international units on these RNA tests, whereas the DBS, while not perfectly sensitive, is sensitive down to 600. And so we felt that the vast majority of people who had a negative DBS would also have a negative viral load. And again, if you don't get the lab, it's not, you don't have anything. And so we wanted to start there, and we do some counseling around that as well. Only 75 total known treatment failures or reinfections. We're not doing genotypes, we're not doing any of that. It's very challenging to separate the two. It's mostly based off history. Probably about half of our positive RNAs after treatment are reinfections, and about half are treatment failures. And many of these people have been cured since who had a positive RNA. So this is my favorite graph of this, and I really, really wanted to, this is what I really wanted to have an updated data piece here. It's a little bit complicated. So the dark green line here is treatment initiation after the percentage of people with a positive PCR who are initiated within the first 60 days after diagnosis. The blue line here is the PCR positivity rate among all people who are screened, and the light green line is the percentage of people who had a positive PCR who were ever treated. And what you can see is early on in our program, these are just year-based screening cohorts. 95% of the people who were diagnosed have been treated. If you remember one of those first care cascade slides, it was only like 40%, right? So we picked them up eventually. And again, it's that web. How are you going to find them again? How do you keep that relationship? How do you keep coming at them? So a lot of it is just the more time, potential time you have exposure to our system, or in general now, we're pretty much citywide. We will find you, we'll get you treated if that's what you want. And then this here, this is the treatment, the percentage of people who are treated early on. So yeah, we did not get people in very well early on because of all of the barriers. And then once we removed a lot of those barriers, and we still had a population of people who were a little bit easier to treat, maybe who really wanted treatment, had been denied treatment for a while. So we were able to get people in very quickly for a while. And then again, those numbers start falling off. And so this could be looked at as a failure, but really this is, we're getting further and further and further into this much harder to treat population. We're doing outreach-based screening. These are people who don't want to come into the clinic. And so the percentage of people who we have diagnosed, who we've treated, has fallen substantially. And some of this is just a cohort. So in 5 years, the same population, I suspect, will have a high percentage of them will have been cured. But the most exciting piece of this for me is that this is the PCR positivity rate in our population. Like this is like, this has made my work, like, this has made it all worth it. You know, this is what elimination looks like. Some of it is that we were doing risk factor based screening early on, so we're going to have a higher percent positivity rate. But as you get further into this, we are dropping the positivity rate in the population. So it's really exciting. All right, almost done with these care cascade slides. Thanks for your patience with all of this. So this is just an example. This is very early on. We implemented DBS screening in opiate treatment programs, where first we offered either the dried blood spot or phlebotomy-based labs. And you can see that even though we offered both, 700 out of the 789 people who were offered either, 785 chose to get the dried blood spot done right away. Even outside of a setting like the OTPs, dried blood spot is preferred vastly over phlebotomy for lots of reasons. It's also good for OTPs because we can do a syphilis test on dried blood spot. And so OTPs have to do TB and syphilis because 1970s rules. And we allow the OTP to have control over that, where if they have to send someone to the lab, if they don't get their syphilis test done, they actually have to take them off their methadone. So this is also addressing some of the barriers to opioid treatment programs. And we're now in 6 OTPs or more, some in Multnomah County and some outside Corvallis and on the coast. And we have thousands of people who have been tested. And working our way again through the existing clinic population is always the challenge. But, and I'm not going to go into this data in any depth, they're a harder population to engage, and so we're working on those systems. This is actually not our team anymore. Megan is the only one who is here currently in our outreach team, but we have 6 folks still who are doing this work. They are absolutely the most important part of this work, so much more important than what I do or have done. And some of these folks have been used to use. We're really focused on people who are harm reductionists is the absolute necessary criteria, but then we also really try to get people who've had past experience with use. A couple people who are on this team have been treated by our program in the past for Hep C, and just really lovely group of humans. They make it all happen. All right, quick pivot. So the other aspect of my work that I've done here is through the Oregon Hope Study and OHSU, which is a NIDA-funded study. And as you saw on that map early on, this is a rural problem, even more so than it's an urban problem. But access to care, especially non-stigmatized care in those settings, are really, really challenging. So we tried to develop a program to address that. I ran a Hep C echo focused on developing elimination systems like this for years, and specifically targeted all of these counties that we'll talk to you about for this next intervention. And it's helpful, but you lose those providers. It's still hard to get patients in, and so we needed a different approach. So we engaged peers. I'm a huge believer in peers. People who have a long history of substance use have a PhD in living the life of someone who uses drugs that I will never be able, even though I feel like I've worked with this population for such a long time, I'll never be able to even approximate. And so these are some of our peers. They do incredible work in harm reduction engagement and just walking alongside people in their own community with a lot of shared cultural identity. And they do Hep C and HIV rapid testing in the community. And we wanted to see if we directly from the peer, just take the health system out of it, tested people and then linked people to telemedicine, what would be the impact? So again, the same counties these are the counties, like this is the general area, not to get into too many details, where we were enrolling people. In the Oregon Hope study, we enrolled 6 different counties across rural Oregon. And we linked them to a telemedicine visit. The peers would facilitate the visits with their phones or with a tablet. In the community, I would do these visits with people in front of a trailer or in a camp smoking a cigarette, and we'd start them on their hepatitis C treatment. The peers would drive them to the lab to get their confirmatory test done. They would again be out there and constantly present to help engage people and then help them with harm reduction supplies. And so we randomized people to either the telemedicine group, or enhanced referral to usual care. So peers would help engage people with the clinic. They didn't follow them along in the same way. They didn't offer medication lockers like we did with the telemedicine arm. But these are largely clinics that had been through my ECHO program. And then they were linked to providers here or pharmacists. A lot of this work that we do at Central City is done by Hep C pharmacists here in Portland. And these are all people who were non-stigmatizing providers who the peers could vouch for. That's really important. This was just the randomization. And the people so we recruited a total of 203 individuals for the Oregon Hope study. High 62% male, 88% white, with some Hispanic and other populations. 70% houseless. That's a huge houseless rate. And houseless in Oregon, rural Oregon, is really rough. Like you're never able to actually stay in one place longer than a couple of weeks or a month or so. Camps are constantly being stripped. So that's really hard to continue to engage people with that. In a very high percentage of methamphetamine use and fentanyl and heroin use. So not ambiguous results. In the telehep C arm, 63% had cleared hepatitis C at the SVR12 out time point. 16% cleared in the enhanced usual care group. Of those, I think only 12% had started on treatment. So many of these were spontaneous clearances. This is why we use the viral clearance as opposed to SVR12, because we did these tests on everyone who was randomized, not just people who started on treatment. So really looking at what is the population impact of this intervention. 86% initiated on treatment in the telemedicine arm versus 13% in enhanced usual care. and obviously a much bigger difference in treatment completion too. So pretty profound results. These data should have been published months ago. Clinical Infectious Diseases has approved that, or has accepted the study or the manuscript a couple months ago. We're still sort of waiting, partly because the Biden administration is writing a parallel commentary, and I think they delayed it for whatever reasons, but it should be released within a day or two, I think. And these are just these numbers again. So I'm running through a little bit here. I'm going to cruise through. The other thing we try to do in this study group at OHSU is really quickly translate research into implementation. And so within a year and a half or so of the Telehep C study kicking off, we started implementing this in these different communities using peers from a grant called the Prime Plus grant, which is really amazing work that Jude Leahy and others at the state have kicked up. But there are peers in most Oregon communities now doing this work. And so PATHS has been expanded now to, I think it's actually more like 24, 26 counties doing the Oregon Hope Protocol. And there are a couple hundred people who have been cured in this, but it's just really getting kicked off now. And they're also now doing a cluster randomized controlled trial looking at the DBS and the D-check and doing a prospective validation of that in these communities. So yeah, it's all really exciting, and we're hoping to expand this to everywhere. You know, I think that what we really need is something like the Biden administration's elimination program to fund these sorts of interventions. Like, you can't fund these through health systems at this time. So I'm wrapping up. Thank you all. Just start somewhere. If you want to do something like this, if it's not Hep C, start somewhere. Don't forget the big picture and speak up, because you can actually make a difference in policy. Create and weave a wide net, foster interconnection, be patient with people, approach people with love, they will come back. You can't build systems without heart or have heart without systems, so you need both. And I really encourage you to get involved with other community organizations like OTPs. They're often very separate, but they have similar goals, and you can sort of find what their interests are and try to build something that works for them. And cut out steps of the care cascade. You can implement this. You can use that concept in any aspect of healthcare. And I will stop there. Thank you.
Thank you so much for sharing just an incredible body of work. I'll take some questions from the audience here.
Dr. Seaman, I just want to stand up and cheer. It's so inspiring. Well done.
Thank you.
Yeah. I was interested, as you talked so much about the peer group, and I'm curious about how the therapy is delivered. You mentioned the medication lockers. Stakeholders might have had good ideas about directly observed therapy or other ways to provide the treatment. I just wondered if you could talk about how your peers informed what you decided to do there.
Yeah, well, I think the peers informed the study creation in many ways. I think that's, I presented this study at INSU, which is the International Network of Hep C and Substance Use, which, by the way, there's a symposium I'm running tomorrow here. It's sold out, but there's a wait list. It's run by INSU, all about this kind of work. But I closed the conference 2 years ago, or last year, I guess, with this, and for me, like, I saw all of these studies that were designed clearly by doctors, like directly observed therapy, and then these studies that were clearly involved, the communities were involved in designing these. The ones where the communities were involved, there was as little healthcare as possible. And the ones where the doctors involved, it was like, how can I get in there and make sure I do it the right way? Those ones, they're all negative trials, you know, like directly observed therapy. When you get people, directly observed therapy does marginally increase cure rates among people who finish the treatment, but people can't do it. And so when we're looking at, this is where, again, care cascades, where does the care cascade start? It's not with when someone starts treatment. It starts with before someone even knows treatment exists And that I think is the big difference in it. The way the peers, so basically the peers were just sort of the interface between this terrible healthcare system and people who had Hep C. And I mean, I can't navigate my own insurance, and I have lots of education in this and health system knowledge. And so they were just every step of the way there to, like, when the phlebotomist was like giving them bad looks because their veins were the participants' veins were hard to access, they would have those conversations with them, and they would be there with them, and they would help correct those systems issues. They would drive them to the lab. They would, and that's for all participants, not just the tele-Hep C group. They would also, we had medication lockers at all the SSPs, so people had a place to put their meds. Like Maverick comes in a football, it's huge. And then they would also help, that's also an address to send meds to for people who are houseless, and they would help navigate some of those barriers. So they did all the things. They did so much more than peer work. And they would try to track people down in camps and so on. So I think that being out there in the community is truly the biggest thing, and someone who they can trust and they can use common language and so on.
Great. While we wait for any other questions in the room, I'll offer one. Sometimes the hospital is a point of contact with the healthcare system for people, and sometimes a new diagnosis of hepatitis C is made in that setting. Any advice regarding counseling of a new diagnosis and sort of practicalities of referring people to meaningful treatment opportunities when that diagnosis is made in the hospital?
Yeah, so I think first, the important thing is to do the work up front to identify if you don't know where to refer people, to set up very clear relationships in advance so that and I think it's almost irresponsible to, I think you should screen people. I'm not saying don't screen people, but you should, if you're going to be screening people, you should have done the work to actually know where you're going to send them, because diagnosing someone and then not offering them a treatment can be harmful. And so I think that's part of it, is like do the work up front to set those systems up. Here in Portland, you can send anyone to us, and there are, email me or whomever, and we'll get you contacts and we'll get people in. And there are also, I would encourage you to try to, there are the OHSU, a friend of mine, Jane Babiars at OHSU, started an inpatient treatment for Hep C program. So you have people coming in for 8 weeks of IV antibiotics for skin and soft tissue infections or endocarditis and so on. And so getting those people treated in-house is another option. There are ways to do that. Yeah, and then internally set up your own treatment referral systems. You have a pharmacy-based program. Cut some of those steps out of that care cascade, but get people in directly. So just set up the system in advance, or when you identify that it's a challenge, that's an opportunity to say, okay, we really need a system for this, for warm handoffs and so on.
Thank you for your presentation. It's very inspiring. I just had a question. You've touched a lot about the outreach and the approaches to outreach. There's like a lot of up and coming systems in terms of like reaching out to patients when it comes to like street care. So I was just kind of curious how that may play a role, or is that something that you foresee being more of implemented when working with patients in terms of like the demographics and you mentioned the trust factors and things like that.
So like street medicine, or yeah. So right now, most of our outreach work is specifically around Hep C and HIV and bloodborne pathogen screening, and also giving Narcan and when we can, safe syringe supplies and so on. We would love to do more of the street medicine based approach. At Central City is getting a van and a couple of vans to do this, and we're going to integrate with that work. Yeah, I hope it is. I think that so much of it is about just being out there, being kind, helping to repair some of the wounds. I think people are we have stigmatized people for so long that, you know, we often, you know, see patients who come in who have these like really, really advanced skin and soft tissue infections, and then we judge them for that. But the reason why they didn't come in earlier is because they don't feel safe in healthcare systems. And so a lot of it is, yes, get out there in the community so people don't have to come in. But I really think, especially in like as residents, you know, in a residency program, identifying problems in your healthcare system, identifying providers and nurses and other parts of the system who are causing harm and fixing it and speaking up about it so that we no longer have to go out into the community as much and people feel comfortable coming in.
Thank you. I want to acknowledge we're right at 9 o'clock. Dr. Seaman, thank you so much for both your presentation and your work.
Thank you.